From Wish TV and Community Health Network, this is a Health Spotlight Town Hall Special.
Good evening and welcome to this Wish TV Health Spotlight Special. We're proud to have partnered with Community Health Network to shine a light on some of the top medical issues facing central Indiana and really all of the state. The COVID-19 pandemic has dominated headlines for more than 2 years now and pushed some other conversations to the side. So tonight, we want to spend the next hour talking about cancer. It's the second leading cause of death here in Indiana. The American Cancer Society estimates more than 13,500 people will die of cancer this year here in our state, and that there will be more than 39,000 new cases diagnosed in the state. Cancer treatment in Indiana is about to take a major step forward. Just this spring, Community Health announced an agreement with the MD Anderson Cancer Center will create the first MD Anderson Cancer Center in the Midwest. The goal? Create a huge array of new treatment options without patients having to leave Indiana. Let's get more with my co-anchor, Alexis Rogers.
Well, joining me now is Dr. Pimaraju, and honestly, this heat here where we have it, you guys are even hotter where you are. Talk to me a little bit about this partnership. MD Anderson, a lot of people are very excited about it.
Well, Alexis, thanks for having me on. I am also one of those people who's totally excited about this. I think it's not just a joining, Alexis, of the people of Indiana and the people of Texas, but it's a joining of two institutions, two ways of doing things, and exchanging best practices across state lines. And so this partnership means the world to our patients, their caregivers and families who are helping them face their cancer, and really to all the providers at both institutions as we link up and join our futures together for the betterment of our patients.
There's so many people that say, okay, Alexis, how does this work? I'm here in Indiana, they're over in Texas. How will this work for patients?
Well, that's a great question. I think oftentimes in any new partnership or a developing one like this has for many years, there's lots of questions. The good news is any and all. We as MD Anderson are here to serve and to serve in this partnership. I think there's a couple of ways that folks can benefit right off the bat. One is what I mentioned earlier, this exchange of best practices. So clinical care here in Houston at MD Anderson has been optimized, perfected, really improved over time. And we want to sort of get that out there to everyone, no matter where you are. Two, there's many things that we can learn from our colleagues there in Indianapolis, and we want to institute what works best for our patients and for our families in that partnership. And then finally, we can also have a joint partnership for referrals of patients back and forth to the campuses and try to really streamline surgeries, radiation oncology, clinical trials, science, everything between the two campuses, and not let physical distance be a factor.
It's so interesting to me because you know this firsthand. For people in their care teams, it becomes like a family of their own, right? Like I know with my care team, I know what my doctor's got going on. He knows what I have going on. He knows what I'm excited when I'm not. So why was Community such a good fit to combine the two?
This is exciting. As you know, I had the honor of recently visiting with my leadership here at MD Anderson to Community, and I was blown away. I know my colleagues were too. It really comes down to the people and the relationships. And what I saw from the doctors, nurses, and other healthcare providers, pharmacists, navigators, is that there is a real dedication to the patient and the family overall. The cancer is one part of it, the treatment is another part of it, but it's what you said. It's about developing relationships. And here at MD Anderson, we found that that goes a very long way. So I was really impressed with not only the physical structure and the facility, it's a beautiful new hospital for people who haven't checked it out yet, but it's what you said, it's the relationships among the healthcare providers and then to the patient, the family. We look at this as an extended family. And so it means that for the citizens of Indianapolis and Indiana, we just have a lot more folks who are caring for each other. And at the end of the day, we're all in this together.
You know, let's talk about trials real quick. I think some people get a little confused and sometimes even anxious when we start talking about trials. I think of my own family's journey with my mom when she had cancer and how trials really kind of gave us a lifeline. So what would the availability of trials be, especially for the patients here in Indiana?
Oh, that's important. That's one of my passion areas. So you hit it on the head here. I think the main thing I can teach folks is clinical trials are not just, quote, last-ditch options or some new drug that came out of the laboratory. That's actually a small fraction of the clinical trial. So in cancer care, Did you know that only 5, maybe up to 7% of Americans are ever enrolled on a clinical trial in the setting of cancer? So that's a very low number. Clinical trials can be known FDA-approved drugs that are given in a new combination or some combination of new and older drugs in the frontline setting, relapsed, a whole bunch of different options. I think the key is that to know that MD Anderson in Houston, we have essentially the world's largest number of active clinical trials for patients. And we, exactly what you said, we want to open those up to folks all over the United States, all over the world, frankly. And one way to do that is to partner, as you said, in these type of partnerships, to be able to have a way for patients to go back and forth between the campuses, open up clinical trials together, and then have a central way of looking at the data and the findings together later on. And that's what we hope to do in partnerships like this.
Okay, so Community is one of 6 partners. Explain this to me.
Oh, sure, yeah. Well, I think it's exactly what you've been asking about. So as the MD Anderson has done so much good in Houston and in Texas, the part of the mission is to then spread that to everyone all over the country and ultimately all over the world. And I think these best practices in surgery, radiation, chemotherapy, clinical trials, there's a certain method and a way that we've acquired, right, over decades and generations. And so our leadership has designed a way to officially start to partner with sites across the United States. And as you said, the CHN community with you there in Indianapolis is the 6th, only the 6th one of these official partners. It requires a lot of due diligence, a lot of time between the 2 institutions to get to know each other, to make sure the practices are aligned, and then, as you said, ultimately to be able to crystallize the partnership with the human relationship. So it is a very distinct honor. We're so proud to work with CHN, to know that they put in the time to get to this status point. And then, like you said, now that all this is official, we did the grand opening, let's start to work together to improve the lives of patients in Indiana, and then to have this joint partnership go forever and forever.
I love this. You know so much. I feel like I learned so much just by listening to you. My grandma used to say, you don't let people who know a lot go without asking them what piece of wise advice have they learned in this process. So I'm going to ask you that as we close. Throughout all of this, the partnerships, learning from your clients, from your patients, what have you learned throughout all this? A word of encouragement for the people.
Well, I was inspired to my visit to Indianapolis to see the CHN team and to meet with some of the patients there that we have jointly between MD Anderson and Community. And one young patient who spoke at the event was so poised, so seasoned by her journey at such a young age. And I think the take-home point is this. If you're facing cancer, wherever you are in the United States, and particularly if it's a rare disease or a rare cancer, this is what I want the viewers to know, Alexis, you're not alone. Even if it's a rare disease or a rare cancer that only affects 500 people a year, 1,000, up to 200,000, partnerships like this should let you know that there are specialists working on those cancers, both in the research lab and in the clinic. And partnerships like this allow that expertise to come from afar to be a local presence. And so that's the key, is if you have cancer in 2022, you're not alone. There is access to greater clinical trials, therapies than what's available in your neighborhood, and partnerships like this make it happen.
Dr. Pimmaraju, thank you so much for your time.
Thank you, Alexis, for your time. Happy to join you anytime.
My name is Arati Tukalas, and I'm 23 years old. In the summer of 2021, after many days of not feeling very well, a biopsy was done and I was diagnosed with acute lymphoblastic leukemia.
So go ahead and access your port, get your labs going.
To say that your world is turned upside down is really an understatement. When you are dealing with cancer, you need people around you who are going to be quote unquote more aggressive and more proactive than the cancer itself, because it's such a fast growing disease. When you're at MD Anderson, you get the feeling that there's probably not a lot of places like it in the world. The level of care, the treatments that they're doing, it's incredible. And you do get the feeling that you are in a very safe space, in a very good space where you'll get better. My doctor at MD Anderson, Dr. Kantarjian, who's also the director of the program, he has the nickname of the Pope of Leukemia. Like he's curing cancer. So to be able to have people who have that level of experience, in combination with the kind of care and the kind of people here that care only about their patients, I think it's just a very good combination. So we're good for now, but maybe I think that this is really a step forward because the level which they communicate with the top hospitals in the world, which is MD Anderson, I think that that's really, they're setting a very high precedent. So for you to be able to have the care which is going to save your life, and to also be able to be in a semi-familiar area, town, city, that's really important as far as keeping you grounded and making you feel mentally, emotionally safe. Now it's almost like full circle. I was diagnosed in Indianapolis. I was sent to Houston for really heavy treatments, and now I can continue my treatments, which have a while yet, but I can continue them close to home. And I just think that I just feel very, very fortunate.
And she was the patient that was just referenced in that previous interview. So what does the MD Anderson agreement mean for doctors and cancer treatment here in central Indiana? I took those questions to one of the top oncologists at Community Health. Why partner with MD Anderson?
MD Anderson probably has the largest collection of cutting-edge innovation anywhere in the country. So essentially, when we partner with them, we've partnered with the largest repository of cutting-edge technology in the world, which is essentially the #1 cancer center in the country and the world. So essentially, we want to deliver what they do in Houston locally.
Yeah. So in your opinion, how will it change or improve the outcomes or care for cancer patients?
Essentially, you know, when you have access to cutting-edge technology, people who are world leaders in the best cancer care that we know in the world, essentially there's no place in the country which has everything, but MD Anderson has the largest repository together. When we build a partnership with them and subject ourselves to their standards, practice guidelines, we essentially are bringing that to our local community. So essentially, it assures people that you're going to get state-of-the-art care and state-of-the-art processes over here. You also get access to cutting-edge technology and clinical trials over here. That should improve care naturally.
Hopefully, right? The story that we saw earlier was extremely powerful. Is it indicative rather, of the kind of approach that you take with patients?
Yes. So this is something we've tried for the last 3 years. And before that, it was an informal process. Essentially, if you look at when Ariti went there, it was an informal process which got her there. Now we're trying to formalize it and make it part of our basic DNA. If you look at the clinical trial that Ariti participated in, there are 40 patients on that study. 4 of them were from Indianapolis who had been sent there as a part of an informal pathway. But I can tell you that for those 4 patients which went there were another 6 who couldn't, and their outcomes have not been great.
How will the availability of trials change outcomes for patients here in Indiana, sir?
It allows access for them for these newer drugs for which they would have to travel outside, which for a large number of people was not possible. Specifically, for example, who are in the Indiana Medicaid program, it was impossible to send them out. Now, they can get access to it through community health networks right here because insurance is removed as a barrier for that. Most of these drugs would have been available to people 12, 18 months or 2 years down the road. But for somebody in cancer care, 2 years is too long.
Yeah.
So that should improve outcome for them. I think those are the 2 major areas. Last but not the least, your physicians become familiar with the newer drugs before they are on the market. So they're better at using them than if you run through the natural course on how they become available to the public.
Dr. Bhatia, thank you very much for taking some time on this day. Thank you.
Thank you so much.
And coming spotlight on women and cancer, including the tests every woman should know about.
You're watching Wish TV, Indiana's only statewide TV news network. Health Spotlight, presented by Community Health Network.
And welcome back to this Health Spotlight special tonight. We're proud to partner with Community Health to talk about the fight against cancer in central Indiana. We want to turn now to cancer in women. Let's start with News 8's medical expert and former Surgeon General, Dr. Jerome Adams. He's with WISH TV medical reporter, Dr. Mary Gillis.
So what types of cancers are women at most risk for, and why?
Well, we know that women are at risk, obviously, for breast cancer at a higher rate than men, but also for cervical cancer and uterine cancer. And the great thing is that we can catch breast cancer early if people get their regularly scheduled mammograms, and most all insurance will pay for you to get that preventative mammogram. So we need to educate women about that and make it easy for them to get their mammograms. Again, we know that cervical cancer can be prevented with the HPV vaccine. So we need to get young women in particular vaccinated against HPV so we lower their cancer risk further down the road.
Well, and speaking of the cancers, how many women die per year of, let's say, breast cancer?
Well, it is in the hundreds of thousands, and when you look globally and in the United States, still far too many. We've made a lot of progress through, again, efforts such as the Race for the Cure, raising awareness as well as raising money for cancer research. But we know that, again, there are disparities. People of color, people who live in poverty, people who don't have health insurance still have rates that are far too high.
Well, we have been making advancements in the field, and are we making enough progress? And if so, what needs to be done?
Well, we're making a lot of progress, again, because so many groups out there are committed to raising awareness, but we're not doing it fast enough, and we're still focused too much on treatment and not enough on prevention. So good news, but also a reality check that there's still much more work to be done when you look at the fact that cancer is still the #2 cause of death in this country.
And Dr. Adams, can you talk about the importance of early detection? How do we get women back out there and to get their checkup?
Well, one of the things that really breaks my heart is when you look at the fact that, for instance, African Americans don't have higher rates of cancer in many areas than other people, but that they have much higher death rates. And that, in many cases, is because they're diagnosed later and at later stages, and it makes it harder to treat those cancers. So it is critical for people to know that cancer is not the death sentence that it once was. We have amazing treatments out there, and you can live a long and healthy and full life even after a cancer diagnosis, but we've got to catch it early. The sooner you catch it, the more effective the treatments are. And that is why we're always on people about screening. And I know people's lives are busy, but what I would say to individuals out there is you can't take care of anyone else if you're not around. And we want you to be around for a nice long time to see your kids, to see your grandkids. And the way we do that is by taking care of our health. And part of taking care of our health is getting our cancer screenings.
Well said. Thank you, Dr. Jerome Adams. We'll talk with you and Dr. Mary Gillis a little bit later in the hour. We want to turn now to continue the conversation to Dr. William Lowry. He's a gynecological oncologist with Community Health Network. Dr. Lowry, thank you for being here. We really appreciate it.
Thanks, Phil.
What's the biggest concern when it comes to women and cancer?
So, I think Dr. Adams outlined some of the concerns in some of the more common cancers in women are breast cancer, colon cancer, lung cancer. But from a gynecologic standpoint, the most common cancers are endometrial cancer, cervical cancer, and ovarian cancer. And a theme with a lot of those cancers is really twofold. Number one is prevention, obviously, and the second is screening. And so the biggest concern is really making sure that, number one, we're doing everything we can to prevent women from developing cancers, and then number two, in cancers that we can't prevent, making sure that they get early screening, regular screening, the correct screening, so that we can catch these cancers at the earliest stage possible when our treatments are most effective.
When you talk about prevention, what exactly do you mean? What are you talking about?
Absolutely. So Dr. Adams referred to the HPV vaccine. There's been few things in medicine that have had more of a profound impact in decreasing cancer burden than the HPV vaccine appears to be able to do. Cervical cancer used to be or still is a big killer of women.
Yeah.
But being able to prevent that disease altogether has been profound in decreasing the incidence of this cancer. Also in prevention, we know that one of the biggest risk factors for endometrial cancer is obesity. And so if we can get in front of that and educate women that losing weight, having a healthy diet, exercising can actually decrease their cancer risk. And it's not only endometrial cancer, it's other cancers that obesity is a risk factor for.
Sure. What about treatment when it comes to women and cancer? Are we seeing basically a better response to treatment than we have in the past?
Yeah, and so again, a lot of our treatments are most successful when implemented earlier in the disease process. And so treatments kind of dovetail with screening, and that if we can get adequate screening to the most people, then we can have a much better impact. In diseases like ovarian cancer, which there is no screening for, we've made remarkable headway in the treatment of those women over the last several years with introduction of new drugs such as PARP inhibitors and things like that have made a big impact on survivability of these diseases.
Detection is also always a concern as well. Are we getting good results when it comes to that part of the story?
Yeah, absolutely. And so when we talk about screening tests for gynecologic cancers and early detection, Pap smears are probably the most important thing that a woman can do is get regular and timely Pap smears, because that's really, when we talk about gynecologic malignancies, one of the best screening tests and one of the best ways of catching a disease early.
How would you rate that? Is that the most important detection?
So yeah, so as far as the when we talk about women's cancer as a whole, obviously your mammograms are really important. Your colonoscopies are really important, but getting a Pap smear is also as important as those other screening tests.
Talk a little bit more about the HPV vaccine, if you can.
Sure.
Delve into that. Yeah, let folks at home know how important those are.
Yeah, and so the HPV vaccine's recently been approved for not only young women but also boys, because we know that the HPV virus is passed back and forth between women and men, and that men don't have the disease burden that women do, but by vaccinating young women and young men, that hopefully we can eradicate this HPV virus and completely prevent some of these cervical cancers, also oropharyngeal cancers as well.
I think this is a good conversation. Do you see the same type of resistance that we've seen from COVID-19 vaccines and other vaccines when it comes to the HPV? And if you do, how do we overcome that?
Yeah, and so initially, when this HPV vaccine first came out, there was a lot of hesitancy. One of the hesitancies would be that, well, if you vaccinate somebody, it will make them less careful, less likely to use protection when they have sex, or more promiscuous. We've seen that that's absolutely not true. In over the last 10 years, we've seen the uptake go from about 50% of young people being vaccinated, almost 75% of young people being vaccinated, and so certainly we've seen an uptick in that. How do you overcome that with education? And I also think as this becomes more commonplace and we see the impact that the vaccine has had, more people are willing to get the vaccine for their children. And it's a safe vaccine.
Yeah. Education is the key, as it usually is,
the key.
right? So for folks at home who maybe have a son or a daughter, what age should they be thinking about the HPV vaccine?
Really, it's recommended for kids 12 and up, and so 11 years old, 12 years old and up, and so as kids are going into middle school, that's really when you should start thinking about getting them vaccinated, because really the vaccine works best if it's if it's given before they're exposed to the virus.
Right. I have about a minute left. So what do you want folks to know who are maybe watching tonight or watch this on wishtv.com at some point when it comes to women and cancer? Just kind of a takeaway.
Man, number one, I can't emphasize getting your screenings enough. Your mammograms, your colonoscopies, your pap smears, regularly seeing a physician, discussing any new symptoms that you have with your physician, but regular medical care. If you're getting regular medical care, you're likely to get your screenings in an appropriate manner, and so I can't stress enough how important it is for regular medical care. Also, weight loss, exercise, healthy diet, so important in preventing cancers as well.
It's good that we're through this COVID-19, not totally through it, but getting there.
Getting there.
And we can have these conversations.
Getting there.
Dr. Lowry, always good to see you. Thank you so much for taking some time. We really appreciate it.
It's my pleasure.
Thank you. Coming up, the impact of the COVID-19 pandemic and its impact on the fight against cancer in Indiana, the challenges and the unexpected benefits, next on this Health Spotlight special.
You're watching Wish TV, Indiana's only statewide TV news network. Health Spotlight, presented by Community Health Network.
And welcome back to this News 8 Health Spotlight special. We're spending this hour talking about the fight against cancer. For our partners at Community Health, it's one of the key focuses for 2022. There's a new urgency in the cancer fight now. 2 years of the COVID-19 pandemic have disrupted medical treatments and doctor visits as well for people throughout Indiana.
The pandemic, I know it's summertime now. We're here in 2022. We're still talking about the pandemic. Is it still impacting you all in the way that you're able to care for your patients?
It is. It's such a smart question because, I have a family, you have a family. Everyone wants to move on, Alexis, from this, but the reality is here we are in year 3. There are many patients and folks who are still at risk, particularly our immunocompromised patients, many of whom will be part of this partnership. So for us, we both take it very seriously, but also try to help folks to move on and move through the pandemic. So as you well know, life has to go on. Cancer, leukemia, none of this took a break because of the pandemic.
It delayed screening in the first 3 months when it hit us. We were in a shock, but because it is regarded as an urgent situation, I think all of us rallied in, and I think care continued. As a matter of fact, at the positive end, we landed up using technologies that we did not anticipate before. For example, telehealth, which had a number of regulatory barriers and also barriers in terms of our acceptance. Suddenly we accepted it. And that has actually improved care at the end of it.
I think what we have to do is we've got to use these lessons, both tragic lessons and other things that we've learned, and then apply that to the next patients that we see. And when we're able to do that, and as you said, we're able to expand the mission to other places too. So I think that's what we're able to do right now.
And let's welcome in now with us Dr. Anuj Agarwala, a medical oncologist with Community Health Network. Doc, good to see you. Thank you for joining us.
Thanks.
I want to ask you similar questions that we've asked the previous doctors on this segment, and that is, where are we when it comes to cancer screenings, cancer treatment after the pandemic?
So I think a lot has changed since the pandemic. I think, unfortunately, during the pandemic, we had a decrease in screenings due to a variety of reasons. I think one was access. Healthcare resources were diverted to fighting the pandemic. There was healthcare workers that were diverted from their jobs doing screenings to taking care of patients in the hospital. So I think that was one big issue. I think another issue was patients were concerned about getting screenings. They were concerned about leaving their homes. They were concerned about going into a healthcare facility. So I do think that the numbers have gone up again, but we need to do better.
Right. What have we learned during that time period, and how will it help us moving forward?
Well, I think we've learned that the screenings are important. Unfortunately, we've all, as physicians, seen patients coming in with later diagnoses of cancers, things that may have been caught a little bit earlier. Patients had symptoms that went unrecognized for quite some time because of the fact that they weren't seeking health care.
We've talked about how important screenings are, but why specifically are they so important?
The biggest advantage of screenings is that the goal is to find a cancer at an earlier stage and to hopefully then cure it. Cancer is curable if caught early enough, and so I think that is the take-home message here is screenings are very important and they improve survival.
And the younger the better that we get screened?
I think it depends on what the screening is for, and I think that's it doesn't necessarily correlate in that way. I think that there's different guidelines from different societies that have different recommendations, so it depends on what the cancer is that is being screened for. But I think in general, when the screening, you are eligible for the screening, you should have it done.
Because there have been some guideline changes as well, right? So it's important to kind of keep up with that too. No?
Absolutely. I think one of the most recent changes was that for colorectal cancers, typically most people know that at the age of 50, that is when people were recommended to get their colonoscopies. That has now been changed to 45 for an average risk individual, taking aside family history and whatnot.
Besides screenings, lifestyle also extremely important too.
Absolutely. I think we're learning more about it every day, but exercise, healthy diet, I think that definitely plays a big role.
Has that changed a lot over the years? I know you said we're learning more about it, but hasn't it always been, keep your weight down, exercise, to kind of fight off any type of health issue?
I think we've known that for some time, but now we're learning more data behind it to say that this is actually a true statement. And specifically when it comes to cancer, a lot of times we would say that when it came to cardiovascular disease, but I think we're learning more about that when it comes to cancer.
What type of treatment progress have we made since the start of the pandemic to now?
I think that there's been a lot of different progress that's made over the years, not just during the pandemic. Different drugs we have, different surgeries, different technologies in terms of detection of cancer. But as Dr. Bhatia had mentioned in the earlier segment about the use of telehealth, I think that's really changed the landscape, and there was a lot of issues with whether it be regulatory or just patient or physician acceptance of telehealth that really was a deterrent to making that happen. I think with the pandemic, everybody's eyes opened up and, we're able to do this. Patients who may have had trouble with transportation, per se, they now can see their doctor even if they can't necessarily get there.
It was a necessity during the pandemic, but are we seeing kind of a reluctance now to do telehealth?
I don't think so. I mean, I think there are patients that still like to come to the office, and I think most of us prefer that. But I think there are some things that don't necessarily need it, or for those patients who have difficulty in access, that has been a great way to help them maintain the care they need.
You said you prefer them coming in as opposed
I do.
to, yeah. Why is that?
I just enjoy that the relationships that you build. I think it's easier to build those and more enjoyable in person than it is necessarily over the computer sometimes. But if it needs to be done, it needs to be done.
Sure. Getting back to the pandemic conversation, the screening aspect is also, and I know we kind of circle back on this, but I think it's an important conversation. We can hammer it home. The screening process has also changed, right?
So the processes haven't necessarily changed a ton. It's just the access. I think now everything's opened up again, so people have access to that care. I think that some people are reluctant to get screenings for various reasons. I think one of the reasons people are afraid is what they may find. And I think the message is that finding things earlier is better. It can help you do better in the long run.
Do you see that a lot? Do you see people that are afraid to find out what's going on?
Unfortunately, yes, and I certainly can understand, the healthcare system can be a maze. It can be very difficult to navigate through the system, and, I think that is a reluctance for a lot of people to seeking care.
I have a minute left because we all have family members who are stubborn when it comes to healthcare. So what do you say to somebody in your family or maybe a friend who's stubborn to go get screened?
Yeah, I mean, I think in my population where I deal with a lot of cancer patients, they may have family members that said, well, if I had cancer, I would never seek care. I would never do that. But as they see their loved one go through it, treatments are much better than they used to be, less invasive, less morbid, less toxic, but better outcomes. And so I think that's the message to send home.
Doctor, good to see you.
Thank you.
Thank you for joining us. All right, coming up here on our health special tonight, are cancer prevention diagnoses and treatment affected by race? We talk equity in healthcare with Dr. Jerome Adams next on our Health Spotlight.
You're watching Wish TV, Indiana's only statewide TV news network. Health Spotlight, presented by Community Health Network.
Welcome back to this Wish TV Community Health Spotlight on cancer here in Indiana. Part of our commitment in these specials is to explore and highlight the role of diversity, equity, and inclusion in healthcare. It's also a key initiative for the Community Health Network. So what exactly does that mean when we talk about cancer diagnoses and treatment? That's one of our questions for Wish TV medical expert and former Surgeon General, Dr. Jerome Adams.
Dr. Adams, you are a leader in the area of health equity, and I want to start with inequity as it relates to cancer. Is this in diagnosis and treatment or in prevention strategies?
Well, that's a wonderful question. We know that when you're looking at cancer outcomes, you have to look at whether or not we're doing the things to prevent people from getting cancer in the first place, whether or not we're screening people appropriately, and whether or not we're treating people appropriately. And the best studies have shown us that you see disparities in all three of those areas. There are different subpopulations that are less likely to get preventative services. So for instance, HPV vaccines for preventing cervical cancer. There are people who are less likely to get screened for cancer, and so we know that certain communities are less likely to go in and get mammograms, or black communities are less likely to go in and get screened for colonoscopies and for prostate cancer. And we know that people are less likely to be treated. But what is fascinating is there was a study done in 2019 by the Regan Street Center that showed that in Indiana, actually, people of color were not less likely to be screened for cancer, but they were much more likely to die of many cancers.
Oh, wow. Okay. Well, I mean, what are these why is this happening? Are there certain barriers to prevention strategies and these treatments in cancer care?
Well, I'm the director of health equity at Purdue University, and what that means is that we're trying to figure out how to give people the opportunities to make healthy choices. And we know that not everyone has the same opportunity to make a healthy choice. I'll give you a concrete example. We know that obesity, meaning being overweight, is a predictor of whether or not you're going to get cancer later on down the road. Well, if you live in a community where you've got complete sidewalks and you have parks and green spaces like I do in Hamilton County, it's much easier to go out and walk or to take a bicycle ride or to play with your kids. If you live in a community where you don't have complete streets, where there aren't sidewalks, where you're worried about being hit by a car, or where there may be crime in the area, you're less likely to go out and exercise. So those different circumstances actually put you at a higher risk for cardiovascular disease, for diabetes, and for cancer.
You know, I'm also thinking about food deserts, and I'm thinking about education levels and economics and all those things that in relation to what you're speaking about. But and how does a person who is Black advocate for their health?
Well, I think one of the things we need to do is simply raise awareness to folks. We know that in studies, Black people have said they're not as concerned about cancer as white people are. And so we need to share the statistics with folks. We need to help them understand the disparities that exist. We also need to educate them about opportunities, again, to lower their risk by losing weight when and how you can, by stopping smoking, by going in and getting your mammogram or your colonoscopy at the appropriate ages. But then we need to, again, make sure people have the opportunities to make those healthy choices. So in Indiana, we have the Healthy Indiana Plan. We want to make sure people are signed up for it so that they can actually get those preventative services paid for free and don't have to worry about the cost of going in to get that care.
Oh, and we also have the minority health care as another option that's coming up.
Exactly. So there are many things that are being done on the back end to provide those health care services and to make sure preventative screening is part of those health care services. That's how we can lower disparities. But we also want to get as far upstream as we can and lower those risk factors. We know that in Indiana, the excise tax, for instance, on cigarettes is lower than in almost every other state. And smoking is one of the biggest risk factors for cancer. Indiana has a higher than national average rate of deaths from lung cancer. So there are policies that we can put in place that will actually also lower disparities and lower cancer rates. And I hope that Governor Holcomb's Public Health Commission will actually dig deeper into some of these policy changes we can put in place that help address our health disparities.
Can you speak about some of these initiatives?
Absolutely. So we know that, again, taxes on certain products can incentivize or de-incentivize the use of them. Alcohol tobacco. Those are risk factors for higher rates of cancer. Initiatives to promote green spaces and exercise opportunities. Those are important. We know also that again, making sure people have access to affordable health care, and for preventative services, free, low barrier health care, but also making sure it's available in their community. You can't just go anywhere and get a colonoscopy or a mammography, but we know, for instance, people have seen those mobile vans that go around and offer mammographies for people so that we can screen for breast cancer. That's incredibly important. But one of the things I really want to highlight again is our lower than average rates of HPV vaccinations. So we know HPV causes cervical cancer. It can also cause head and neck cancer. And unfortunately, when you don't get the vaccine, you're at higher risk for getting HPV, which puts you at higher risk for cancer. So we have a cancer-preventing drug out there, but not enough people are taking it. We need education and we need access so that we can help save lives.
Yes, education, access, and money should never be a barrier. So we want to certainly help those people. So, has there been enough cancer research in Black people, and is there an implicit bias? And if so, how do we fix it?
Well, it's a great question that you ask, and there's absolutely not enough research looking at communities of color and vulnerable communities. And so, for instance, the FDA has actually told companies as they're developing new drugs and products, they have to make sure they've got more representative populations. This literally just came out within the last month. The FDA said to companies, you have to have a plan for diversifying enrollment in trials, or else we're not going to approve your products. But again, when you look at barriers, CMS, the Centers for Medicaid and Medicare Services, for the last decade has told people that if you're getting Medicaid, we will not pay for your medical care related to participating in a trial. So it actually discourages people from participating in trials if they're on Medicaid, and we know people of color are more likely to be on Medicaid. Well, that changed in January of this year, and so that's a good thing. But we need to lower those barriers and collect data that helps us understand how and why different groups are at higher risk. So to answer your question very directly, yes, we do need more people of color to participate in trials, but we need to understand there are many reasons why they're not participating in trials. In some cases, they're not the reasons that we expect.
And what you just said, that's so upside down. That's so, I mean, okay, well, and okay, you have the floor. Any last thoughts on this?
Well, I want people to understand that cancer is the #2 cause of death in the United States. And Indiana is ranked number 11 in terms of cancer deaths. So there's a lot of work to be done here. I'm glad to see institutions like Community Health emphasizing the importance of cancer prevention, cancer screening, and cancer treatment. But we need to understand it starts in the community. It starts when we create high opportunity communities where people can be educated, where people can get good paying jobs, because with jobs comes health insurance, where people have access to health care, and even things like making sure you have paid time off from work to go in for your visit, to get your screening. That may be a barrier for someone going in, or someone doesn't have child care, so that mother puts off her mammogram until she has late stage cancer. There are things that we can do to put people in a position to make better choices and to help lower our cancer rates in this state. And that is what I'm committed to. That's what Governor Holcomb is committed to through the Public Health Commission. And it's what I hope we can all accomplish together.
Thank you, Barry. And Dr. Adams, we welcome in once again Dr. William Lowry and Dr. Anuj Agarwala from Community Health Network. We heard Dr. Adams talk about equity in healthcare, and we also know that it's a top priority for community, as you gentlemen know. So do we see differences in the way certain cancers affect Black and African American population across the country? Doc, we'll start with you.
I do think that there's definitely a difference, as Dr. Adams alluded to in some of his comments. I think we know that mortality for Black females is higher than it is for others. I think part of it's lack of screening and lack of access to care.
Dr. Lowry, your thoughts on that?
Yeah, I certainly agree. And one thing that research has shown is that there are some genetic differences that lead to these outcomes. And so including African American women, people of color, in clinical trials, so that we make sure that our treatments are as effective across, all women, is really important.
Dr. Adams kind of talked about it, how important it is to have people of color in those trials.
It's so important, and historically, women of color have been underrepresented in clinical trials, which is a big concern, especially when we see differential outcomes in treatment, and making sure that not only are our treatments appropriate, but that they work as well, in women of color as they do in all women.
Dr. Agarwala, how do we get people that may be skeptical about this to join in on these trials?
Yeah, I mean, I think unfortunately there's a long history of things that have been done in the past that have made people skeptical. But I think that the advances we've made to this point are because of clinical trials, and I think it's important to have the conversation. I think unfortunately clinical trials aren't even discussed with a lot of individuals, and that's part of the problem.
We've talked a lot about scanning and treatment and diagnoses. That's also an issue in the inner city and in Black and African American communities when it comes to getting the scanning early and getting screened early. How do we work against that?
I think one big thing is education and just teaching people and educating people that these things are out there and there's things that they can do. I think also just going out to the communities, getting their peers to get involved and going to leaders to make sure that education is delivered.
Dr. Lowry?
Yeah, and I think one of the big advantages of Community Health Network, and one thing that we try to do as a network, is to take care to the communities that we serve. As opposed to having one hospital in the center of town, we have five hospitals across central Indiana with multiple satellite clinics, in an attempt to bring care to where people are.
Yeah. So you kind of alluded to this a little bit. This didn't happen overnight. I mean, this skepticism, years and years of problems that we've dealt with. So are we seeing that people are maybe a little bit more open to the education aspect, the screening aspect? Has that changed recently?
I think that one of the biggest things is that it's a conversation that's actually that's happening now. For a long time, it wasn't even discussed. It wasn't recognized, wasn't discussed, and so it was never dealt with. The fact that we're even talking about it today, I think, is a big step forward.
Sure.
But now we need to take the next step to actually making action happen.
And how we do that, Dr. Lowry?
I think it's just being cognizant of the issue and making sure that we're discussing these things with our patients.
This is obviously a very big problem. So the small steps that we're talking about, how do we do those? How do we put those into play?
Again, I think it really comes down to education and conversations with patients, including them in the conversation, making sure they're aware that these things exist, and trying to take away or demystify any concerns they may have.
These are tough conversations that I'm sure you have, right? So how do you go about navigating that conversation?
It's not easy. I don't think it happens overnight, and so I think that over time, again, relationship building, helping them understand that you're out there for their best interests.
Yeah.
Yeah, I think it's building relationships with your patients, letting them know that you care for them, and it opens them up to these conversations.
When they push back, though, I mean, do you talk to a family member? I mean, that's probably not easy to do.
Sure, and it's oftentimes it helps to have a second set of ears, especially in these hard conversations. Because I mean, oftentimes when we're talking about clinical trials, that means that they've progressed through their first, sometimes second or third lines of treatment, and so oftentimes these patients are skeptical of what we have to say at baseline, and so having a family member there helps, but also again. Like Dr. Agarwala said, it's building trust with our patients.
I have about a minute left, so really a takeaway from both of you, if you can, 30 seconds.
I think when it comes down to it, I think that just education, conversations with not just your oncologist, but your primary care physicians, and just with your family members, let them know, understanding what people's concerns are to enrolling in clinical trials, and so that anything that needs to be addressed can be to hopefully include more people.
Your takeaway from anybody who's watching this tonight that maybe came into this a little skeptical about the conversation when it comes to cancer and where we've come since COVID?
Yeah, I mean, it's letting everybody know that we at Community care about the Central Indiana patients and beyond, and that we're here to help, and that we really care about our patients and want what's best for them.
I have 30 seconds. So biggest cancer concern for folks this time of year?
Now that it's sunscreen, absolutely. As I say, now that it's nice outside, people people are less likely to want to come to their doctor, and so yeah, absolutely wear sunscreen. Keep your doctor's appointments.
There you go, gentlemen. Good to see you. Thank you for joining us tonight. Thank you. And thank you for joining us from home for this Health Special Spotlight. We're proud to be partners with Community Health all year long, shining a light on the medical issues most important to Central Indiana. You can find this special on our website, wishtv.com. We'll see you back here tonight at 10.